sorry. So we are based out of Bangalore. We are specialized in a prognostication test in the oncology field. We develop and commercialize tests in the oncology segment, precisely prognostication ones. We reached out to Dr. Nirni to requesting an opportunity to present about the organization and the test, the proprietary Indian innovation test we have to the tumor board of Omega Hospital, and he has gracefully agreed, gave permission to us, and also gracefully agreed to be the moderator of the session. And I would like to thank sir for that. Let me start the formalities by introducing Dr. Nirni. And I know I'm 100% sure that none of you would require an introduction of Dr. Nirni because he is well known to all of you. But still, as a formality, sir, let me do that honors. Dr. Nirni is a senior consultant medical oncologist, hematologist, and BMT specialized oncologist at Omega Hospital, Hyderabad. And sir has more than close to 30 years of experience in the field of oncology. Sir has an MD in medicine and a specialization of DM in hemato-oncology. Apart from his illustrious career in India, he also had international stints with institutions like St. Vincent Hospital, which is part of the New York Medical School, New York, and Queen Elizabeth's Hospital, Birmingham, UK. And Dr. Nirni is a member of Indian Society of Medical and Pediatric Oncology, ISMPO, and the Association of Physicians of India. I'm sure over the past close to 30 years, sir has treated thousands of patients across different tumor types like lung, head and neck cancer, ovary, cervix, GIT, breast, sarcoma, etc. I would like to thank sir for accepting to moderate the session, and would like to leave the stage to you, sir, to take it forward. Thank you so much, and I hope the session will be really interactive and informative.
Yeah, good evening, friends. Dr. Manjiri Bakre, she's a founder and CEO of OncoStem Diagnostics Private Limited. She has a gold medal from the R.R. Hui College University, Mumbai, for her BSc, and MSc. She did her MSc from Baroda. She did the PhD from Indian Institute of Science, Bangalore, and she's worked in USA at Mount Sinai School of Medicine, New York, and Morris Cancer Center, San Diego. And she's a founder. She started this OncoStem in 2011, and she is awarded with the Young Scientist Award and the Best Entrepreneur Award, and NASACOM Best Innovative Year Award. And she presented various national and international papers, and she's presented a lot of papers in multiple conferences. And now she will be discussing on redefining prognostic marker in early breast cancer and ISC based approach, because in India we don't have any like Indian based any diagnostics tools, because as a clinician we treat a lot of patients in even early breast cancer with the chemotherapy, but most of the 70% of this early breast cancer, they don't need any chemotherapy, but only 30% of the high risk patients only need chemotherapy. But unfortunately we don't have any Indian based test which can help us to whether to go for chemotherapy or whether to go for direct hormone therapy. We have some of the multinational companies diagnostic tests like Oncotype DX, Mammoprint, and Prosigna. So all this, they are very, very expensive for Indian patients. Most of our patients in our hospital, they are not affordable for that type of money. But we are very glad that we have one Indian-based company which is helping us in treating this early breast cancer properly with very minimal price as compared to innovative or multinational company diagnostic tool. Now I will invite Dr. Manjiri Bakre to discuss about this redefining prognostic marker in early breast cancer and ISC-based approach. Dr. Manjiri.
Yeah. Thank you, Dr. Nirni and the team at Omega for having me present this work. It is indeed my pleasure, and thanks for taking the time. Without further ado, I will start the presentation. Let me just make this full screen. Yeah. So as Dr. Nirni said, mentioned, the title of the talk is Role of CanAssist Breast in hormone-positive, HER2-negative early-stage breast cancer patients. So I think the central question that we all try to answer in hormone-positive, HER2-negative early breast cancer is how to treat them, specifically whom to give chemotherapy, whom not to give chemotherapy. While it is a mild disease compared to triple negative, they also run the risk of late recurrences and so on. So traditional methods in early 1900s were tumor size, node, metastasis level, grade of the tumor, etc. And later biomarkers like ERPR, HER2, Ki67 came up, and they were really instrumental in helping patients get endocrine therapy, especially ERPR, HER2, and from prognostic they became predictive, and they are really helping patients till now. But post that, there are many such things like IHC4, luminal based classification, online tools, etc. But that has not led to any new targeted drugs. Nevertheless, they have helped in many countries to really select patients who would benefit from chemotherapy. And in early 2000s, Oncotype DX and MammaPrint started this whole era of omics-led genomic testing, multi-gene panels to predict the risk of breast cancer recurrence in early stage hormone receptor positive HER2 negative patients. And then that has really, all of these goals at all times for everyone has been to reduce over-treatment of these patients with early breast cancer, with really using a sets of precision medicine rules. And these would really lead, the goal has always been to reduce financial and physiological toxicity that chemotherapy gives to the patients. However, many of these online tools, while they are free, they are often based on Caucasian data, and they don't really, it really doesn't, and they're not very well validated across the globe. So it really reduces the generalizability, the use of these tests across the globe. For example, Adjuvant Online is based on SEER database, Predict and NPI are really based out of UK on primarily postmenopausal women. And IHC4 is also postmenopausal women from France ATAC database in US and Europe. And the challenges are really underestimation of benefits of chemotherapy in patients with small biologically aggressive tumors. So these are the ones that we often tend to miss, as well as over-treating patients with hormone with slightly bigger tumors, and overestimation of survival in younger women under 50 premenopausal. We often think that they have a really aggressive disease, but that's not often the case. Lack of standardization of clinical utility of these tools, and lack of generalizability of these tools on very diverse population, and multiple publications support these conclusions from different Asian countries. What about the genomic test? Prognostic tests have really helped in the West a lot. As you all know, they are performed, all of them, on the surgically resected samples, and typically they would stratify about 70% of these patients as low risk and 30% as high risk. And Oncotype MammaPrint really lead this wave of genomic testing in the US and in Europe. They are widely adopted. They are in multiple guidelines, including AJCC, and they have led to reduced use of chemotherapy and improved quality of life for patients with eligible patients with EBC in the West. However, do they all work across all ethnicities? That is something that has more and more of late come to light, that the short answer is they are not. Kathy Albane presented this, published this post hoc analysis of Taylor-X trial in which node-negative patients, just primarily on node-negative patients, and she showed that Oncotype DX performance is different, is in Black versus white and non-Hispanic versus Hispanic population. The test predicts the overall, the predictions of Oncotype DX, whether they are on IDFS, OS, DRFI, were worse in Black and non-Hispanic compared to the compared population of white and Hispanic patients. And this was prominently showcased in the RS recurrence score 11 to 25 window even more, which is showcased with higher hazard ratios. What about mama print? Mama print has been shown to perform differently in the Asian versus European patients. While mama print typically stratifies in Europe, in various European countries and including the Netherlands, typically it stratifies about 63% patients as low risk and about 65, 45 or 50 to 60 low risk versus the remaining high risk. In Japan and in Korea, mama print stratified about 80 to 86% patients as high risk and the remaining 20 to 15% patients as low risk. So this was in stark contrast to what it showed in the European population. So why do we have these kind of differences of the test performing differently? It could be, because the way breast cancer patients are diagnosed in Asia, Middle East versus the West. So in most of Asian countries, even including Middle Eastern countries I have visited and presented this data, the age at onset is premenopausal younger, a decade earlier compared to West, where median age at diagnosis is 60 plus. The tumors seem to have higher tumor burden in Asia, and primarily they come with one node positive, about 2 to 2.5 centimeter tumors. Whereas in the West, due to variety of reasons, including increased awareness, it's not having breast cancer is not a taboo, proper insurance screening, etc. Most of them are screen detected early stage lymph node negative, less than 2 centimeter tumors, T1 tumors. So our problems are, realistically speaking, disease at a younger age. This is onset at a younger age. And disease is primarily node positive, grade 3 and high Ki67 this thing. On top of that, prognostic tests such as Oncotype DX, Mama, even if they were to work equally well, the price is not suitable for our patients. They are prohibitively expensive and out of reach for many markets, many countries outside of North America, where it's an insurance-driven market. So we felt back in 2011, when I came back to India, and I really had close friends and family who had died of early breast cancer, that we need a prognostic test that is suitable for our patient, which takes into consideration the tumor biology of our patients, and which is also affordable to our patients. So that was really the rationale behind starting OncoStem Diagnostics and developing CanAssist Breast. So we felt the unmet need is CanAssist Breast, which is developed on Asian patients. What is CanAssist Breast? It is an immunohistochemistry-based prognostic test. Immunohistochemistry is performed on Roche's automated Ventana machine for 5 proprietary biomarkers, which I will show you in the next slide. These are not ER/PR, HER2, and Ki67, as most people ask me. And these 5 IHCs performed on Roche's machine are quantitatively graded by oncopathologists trained in our lab. And that information, along with 3 clinical parameters pertaining to that particular patient's tumor, which are tumor size, tumor grade, and the lymph node status of the patient, are the key input into the statistical algorithm which OncoStem has developed from scratch. Our statistician is based in the US. This statistical algorithm includes artificial intelligence-based method called support vector machines, which is very good at modulating complex disease like cancer, where the intricate signaling pathways are well modulated, well represented, and reiterated multiple times, and to give us what is called as a risk score. And the output out of the statistical algorithm is a numerical number between 0 and 100. And if the risk score, that's what we call CanAssist Breast risk score. If the risk score is under 15.5, the patient is considered to have a low risk of distant recurrence within 5 years from diagnosis. And typically 70% of the patients, eligible patients, fall in this category and they can avoid chemotherapy. If the risk score is 15.6 or higher, then patient is deemed to have a higher risk of distant recurrence, and she would benefit from taking chemotherapy to in addition to endocrine therapy. CanAssist Breast has been validated on on close to 4,000 patients from India, multiple sites, multiple hospitals in India, a few sites in the US, and also a few countries in Europe. CanAssist Breast does have a high accuracy, 95% negative predictive value comparable to Oncotype DX or MammaPrint. The patent for 5 biomarkers is granted in multiple geographies, and we have several peer-reviewed scientific publications. I will showcase you the data today, and all of these publications are available on our website, www.oncostem.com, and we will be happy to send them to you as well. So coming to what are the 5 biomarkers that are used in CanAssist Breast, these 5 biomarkers are really, our goal was to really go beyond proliferation and hormonal indices, since by knowing the grade of the tumor and the size of the tumor, lymph node status, we already know the proliferative capacity of the tumor. Hormonal indices, this is only meant for hormone receptor positive, HER2 negative. So we really wanted to go beyond these markers. And so we looked at what really induces a tumor present in the duct, tumor cell present in the tumor in the duct, to really evade, to come out of that tumor, go lose the tumor and microenvironment, go into the bloodstream, and come out of the bloodstream in some other distant organ and form another tumor there. What are the signaling cascades? What does the cell need to gain to be able to do this hard task? It's a very hostile process, actually, realistically speaking. So we, as a cell biologist, that's what I studied, and we looked at 40 different biomarkers, which are really key signal transduction cascades involved in cancer progression, and that leads. Some of the key steps are epithelial to mesenchymal transition, loss of cell addition, invading the blood vessels, and then coming out, going through the MET, the mesenchymal to epithelial transition, come out, excavate from the cells, from the vessels, and form another tumor in another distant site. And via statistical algorithm, we narrowed down these events are well represented by these 5 biomarkers. And those are CD44, 2 cadherins, and 2 ABCC transporter proteins. And that's what is part of our statistical algorithm. This algorithm has been well published in multiple publications. Many of our clinicians, collaborators in India, which I'll show you the sites, including RGCI and Manipal Hospital, Bangalore. Many hospitals have really been instrumental, Jaslow Hospital, in really helping us to achieve this step. And any test needs to be validated in an analytical and clinical validation manner to really able to showcase its quality standards as well as its efficacy. So we have looked at CLSI and CAP guidelines to arrive at the analytical validation, which has been showcased and published. We have also completed the automation of the test, and CanAssist Breast has been shown to work in tissue microarray formats as well, which is critical for doing any randomized prospective study, whose samples are often stored as tissue microarrays. Coming to global validation of CanAssist Breast, the proof of the pudding really lies in validating CanAssist Breast across different geographies, across different ethnicities. And that was really our goal behind not only validating it in multiple different sites in India. These are some of the biggest sites in India that we work with, including Tata Memorial, HCG, Manipal Hospital, Mazumdar Shah, Jaslow, many hospitals. And in the US, we had 3 different sites for working with 3 different hospitals. And in Europe, we have done validation studies in Spain, in Barcelona, at Valdebron, in Germany, in Italy, in Austria, and also in the Netherlands. And I'll showcase the data regarding all this. And the summary of all of these take-home messages: CanAssist Breast works with equal accuracy across the multiple ethnicities we have tested till date. All of this data that I'm showcasing today has been published in multiple publications, including the head-to-head comparison of CanAssist Breast with Oncotype DX. So coming to the data actually, so how does CanAssist Breast help patients and clinicians? It effectively generates only 2 actionable risk groups. There is no intermediate risk zone in CanAssist Breast-based risk segregation. So if you look at the Kaplan-Meier survival curves on the screen, the left side curve showcases all of the patients treated with chemotherapy plus endocrine therapy, distant metastasis-free survival on the y-axis versus time in months. So if CanAssist Breast was performed on all of these patients, it would have segregated all of these patients into 2 distinctly segregated risk categories. Patients with low risk for cancer recurrence, about 70%, and patients with high risk of breast cancer recurrence, about 30% over 5 years. This is highly statistically significant. One may argue that some of these patients did get benefit of chemotherapy even from the low risk category. So we did a subgroup analysis where each of the patients was only treated with endocrine therapy. And in this endocrine therapy alone treated cohort as well, you can see that the low risk patients are well segregated from the high risk patients, and they have an excellent distant metastasis-free survival of 95%, which is far higher than the DMFS of high risk patients, about 84%. This is statistically highly significant. This indicates that CanAssist Breast-based risk stratification is not affected by chemotherapy. It is entirely based on ability of the test to see the tumor biology. And even if the tumors are small, it is able to see the aggressive tumor biology and able to segregate patients who are at high risk even amongst the endocrine therapy treated alone patients. What about, we often see younger patients. So what about patients who are younger than 50 and over 50? Can the test segregate both sets of patients equally well in statistically significant manner? So we looked at subgroup analysis of these 2 sets of patients. And as you can see in both KM curves, statistically absolutely significant segregation was achieved of patients under 50 and over 50 into 2 risk categories, low risk and high risk, in a very statistically significant manner. And the proportions of these patients is also very similar, about 70:30, indicating age is not an issue for CanAssist Breast-based segregation. It truly looks at the tumor biology. What about the lymph node status? As I mentioned in the introduction, our patients are primarily come with 2.5 centimeter, 1 node positive patients, stage 2. So we looked at subgroup analysis where we compared CanAssist Breast segregation in lymph node negative versus lymph node positive patients. And once again, CanAssist Breast is able to segregate both whether they are node negative or node positive in a statistically significant manner into low risk versus high risk across both the nodes, lymph node status, negative or positive. However, the percentage of patients in lymph node negative is higher in low risk compared to the node positive patients who are in low risk. However, the DMFS was high compared to was comparable, and it was much higher than the high risk patients. What about in lymph node negative? Do we see a chemo an effect of segregation by CanAssist Breast in the lymph node negative endocrine therapy alone treated patients? So we looked at patients who were lymph node negative and treated with endocrine therapy and chemoendocrine therapy. And as you can see, once again, in both sets of patients, CanAssist is able to find a finite population of high-risk patients, even in lymph node negative patients, whether they were treated with chemotherapy or not. CanAssist Breast is able to find these high-risk patients even in the lymph node negative patient populations. And definitely the patients who are at high risk have a lower DMFS compared to patients who are at low risk. The low risk patients do very well without chemotherapy. The ET alone patients do have an excellent DMFS of 96%. What about this is really our problem, the node positive patients who are young. And so node positive patients, whether they were treated with chemoendocrine or endocrine therapy, once again, CanAssist Breast is able to segregate them in statistically significant manner into low risk versus high risk, and even in node positive endocrine treated patients, node positive. So this goes to really show that CanAssist Breast is really able to look at the tumor biology very well. Even in node positive disease, there are patients who are treated with ET alone, and they were rightfully classified as low risk by CanAssist Breast compared to the high risk patients who probably would have benefited from adding chemotherapy into their regimen. What about the clinically low risk patients? So these are the patients who often we miss because they have small tumors, less than T1 low lymph node negative, or they are not only T1 lymph node negative, they are in elderly patients. So we consider them as clinically low risk. They may have low Ki67, low, no clear margins, LBI, etc., low grade, etc. But because CanAssist Breast is always looking for aggressive tumor biology, apart from the proliferation indices and the hormonal indices, it is looking at the tumor biology, inherent tumor biology at the time of diagnosis. Even amongst the clinically low risk patients, CanAssist Breast is able to find a finite population of 7 to 10% of patients who are actually at high risk of, actually have a high risk of breast cancer recurrence and would benefit from adding chemotherapy into their regime, which are showcased here, and they have a lower DMFS of 85% compared to the compared to the low risk patients who enjoy a better DMFS of 96 to 97%. And these were all treated with endocrine therapy alone. So this really proves the point that there is I think Dr. Cliff Hardis had mentioned in one of his editorial at the NEJM after having TAILORx data out, that there is tumor biology before tumor anatomy. So although anatomically they were all low risk, but the tumor biology is indicative that there is a population of patients even amongst the low risk patients whom we are missing today from giving chemotherapy, and they would benefit from adding chemotherapy to their regimen. What does CanAssist Breast demonstrate high risk chemotherapy benefit? The short answer is yes. CanAssist Breast, here we looked at the data in a very different manner. We looked at all the patients stratified by CanAssist Breast as low risk for breast cancer recurrence. And amongst this patients who were stratified as low risk for breast cancer recurrence, we tried to see, is there any difference if you treat these low risk patients with endocrine therapy alone or with chemoendocrine therapy? As you can see, these curves are overlapping with a very good DMFS of 96%, indicating when CanAssist Breast has stratified patient as low risk for breast cancer recurrence, whether or not you add chemotherapy to her regime, she does not benefit. She does very well with just endocrine therapy alone. But on the contrary, if CanAssist Breast stratifies a patient as high risk for breast cancer recurrence, as you can see on the in the KM curve on the right hand side of the screen, and these high risk patients, if you spare them from chemotherapy, look at the red line, which has only patients who were treated with endocrine therapy, they tend to recur more often compared to patients who received only who received chemoendocrine therapy, in whose treatment chemotherapy was added. And there is a improved survival from 79 to 93% only in high risk patients. There was no difference in survival in the low risk patients, whether or not you add chemotherapy in the regime. This really showcases that there is chemotherapy benefit in patients who are only stratified as high risk, and Oncotype DX shows the same point extremely well as well. So what about the genetic, geographic or genetic variations? Do they impact, coming to that question of, do they impact the interpretation of biomarker driven tests? So Dr. Purvish Parikh published this data in SAJC, and he did a survey of many oncologists in India, and 74% agreed that biomarker test results cannot be applied globally without validation of the data on the respective patient population. And so we were curious if CanAssist Breast can work equally accurately on the Indian patients versus non-Indian Caucasian patients. And so we have been doing validations across different countries for the last few years. And we compared the Indian CanAssist Breast validation data on Indian subcohort versus the Caucasian subcohort. And as you can see, whether we look at the data in terms of patients who received chemoendocrine versus endocrine therapy alone, in both these sets of patients, CanAssist is able to segregate these patients in a statistically highly significant manner with the similar proportions of risk proportions. In chemoendocrine therapy, it is typically 70-30, and in endocrine therapy treated patients, whether Indian or Caucasians, it is about 78-20, about 80-20, indicating CanAssist Breast is able to work equally well across different ethnicities that we have tested so far. This recent data of validation of CanAssist Breast in Spain, Italy, Germany, and Austria has been published in The Breast earlier in the year. What about, so in absence of CanAssist Breast, we often rely on comparison of, we often rely on Ki-67 and luminal AB based risk stratification. So we wanted to compare CanAssist Breast with these tools that are easily available. So switching gears to comparison of CanAssist Breast to these easily available tools in India. Ki-67 is one marker which keeps us on our toes by having changes in the cutoff, changes in the clone, the way we interpret it, and so on. So as per the latest guidelines, Ki-67 under 5%, those patients are termed as low risk for recurrence, and they do not need chemotherapy as per the St. Gallen's or HSCC guidelines. If Ki-67 value is between 6 and 29%, the patients are termed as intermediate risk, and as per the guideline, they recommend a genomic test. And if Ki-67 value is over 30%, those patients are termed as high risk for breast cancer recurrence, and they would benefit from taking chemotherapy. So given this background, we did a head-to-head comparison of the same cohort with CanAssist Breast. As you can see in the middle Kaplan-Meier survival group, the same cohort was segregated by CanAssist Breast as 75% low risk and 25% high risk, whereas Ki-67 under 5% patients were only 50%. And if you look at the DMFS, the 50% low risk patients were at 93. CanAssist Breast DMFS in the low risk is at 95%. There was no differentiation between Ki-67 low and intermediate, statistically not significant. CanAssist Breast has a higher risk DMFS of 25% patients or at 82%. We were very curious about the 36% patients. Since the guidelines say that perform a genomic test, we tried to segregate these 36% Ki-67 intermediate risk patients using CanAssist Breast. And as you see in the third KM curve, the CanAssist Breast segregated these 36% patients further into low risk versus high risk, 74-26. And the low risk patients do enjoy a higher DMFS of 95% in comparison to 84% of high risk patients. And this is out of the Ki-67 intermediate risk category. So this goes to show that CanAssist Breast is more accurate and more robust and stratifies more patients as low risk more accurately in comparison to Ki-67, and it's a better tool than Ki-67. What about luminal AB? Luminal AB is something we have been doing forever using H-score of ER/HER2 and Ki-67. And you can see in the left KM curve, luminal AB based classification would segregate this set of cohort into two categories. Luminal A, who can be spared of chemotherapy, that's only 31%. They have an excellent DMFS of 96%. And luminal B falls, 70% patients actually fall in high risk luminal B, who would benefit from taking chemotherapy as per the suggestions. However, the same cohort, when we looked at how does CanAssist Breast segregate the same patients, 75% patients fell in CanAssist Breast low risk with an equally good high DMFS of 95%, and 25% patients would were actually under high risk for breast cancer recurrence, and they would benefit from taking chemotherapy. They do have a lower DMFS of 82%, as shown here in comparison to luminal B. The difference in these two cases, the low risk versus high risk is also a lot higher in CanAssist Breast risk stratification. How does CAB compare with multi-gene test? So most popular multi-gene tests are really Oncotype, MammaPrint, Endopredict, Prosigna. And there has been multiple studies to compare those 4 tests. One of them is Optima Prelim, and this data has been published by John Bartlett a while ago, and he showcases that no test is more equal than the other. When he compared CanAssist Breast with Oncotype DX, Oncotype DX with MammaPrint, Prosigna, Endopredict, etc., the concordance between Oncotype with any of the other genomic tests was not very high. The concordance in the lowest category was between 30 to 72%. And the kappa correlation things were not the most impressive. So we were curious, how does CanAssist Breast compare with each of these tools? So we looked at CanAssist Breast and Oncotype DX comparison in a head-to-head comparison. As you can see, CanAssist Breast called 83% of that cohort as low risk. Oncotype called 90% of the cohort as high risk. What about accuracy of both the tests? That is extremely comparable. If you look at the negative predictive value of CanAssist Breast and Oncotype, whether we are looking at total cohort, endocrine therapy alone treated cohort, or node negative cohort, the accuracies are very similar. The negative predictive values are very comparable between Oncotype and CanAssist Breast. We were curious what is the concordance in the low risk category, because these patients are spared of chemotherapy. So we see 83% concordance between the low risk of Oncotype and CanAssist Breast, which is the highest seen so far when you at the face of Optima Prelim trial. And I think many others have also published that the concordance between the 2 genomic tests is not very high. So we are really encouraged to see and happy to showcase that there is 83% concordance between Oncotype DX and CanAssist Breast in the low risk category. And remember, we are at a fraction of a cost of Oncotype DX. So we can give you accurate data even at a low cost. This data has been published in Cancer Medicine. What about comparison of CanAssist Breast with MammaPrint? We see that this is again a head-to-head comparison. CanAssist Breast in this comparison called 67% patients as low risk. MammaPrint called 55% as low risk. And when we look at the concordance between the low risk category alone between these two tests, we see 85% concordance between MammaPrint and CanAssist Breast in the low risk category, and 71% overall. This is once again a really good concordance, and as you know, the price difference is huge between CanAssist Breast and MammaPrint. All of this data I showcased till now is validation of CanAssist Breast or prediction of CanAssist Breast distant risk of recurrence in 5 years from diagnosis. We all know that hormone positive patients can recur up 10, 15 years from diagnosis. So we were trying to validate CanAssist Breast in cohort of patients where there is long-term follow-up available. Typically, this kind of long-term follow-up is very hard to find from retrospective studies, and prospective trials which follow patients to last detail but long-term are the right source of such analysis. So we have been talking to multiple trials who completed trials who have the samples available. One of them is TEAM trial, which is a prospective randomized completed trial. TEAM stands for tamoxifen exemestane adjuvant multinational, a large trial, multi-country European trial conducted in 9 countries, close to 10,000 patients. They used randomization of hormone therapy, 5 years of exemestane versus sequential tamoxifen plus exemestane, and patients were followed for 10 to 12 years. And we have got the first set of 480 patient samples from the Leiden University Medical Center in the Netherlands. It was really very kind of them. We approached them, we didn't know them, but they were willing to share these data. We explained the test, and they were curious whether CanAssist Breast can segregate these patients into risk categories and can predict the 10-year recurrences. Interestingly, this cohort is very different from what you would see a prospective randomized trial cohort like TAILORx or RxPonder, where 100% of this TEAM trial cohort is postmenopausal. 67% is node positive, 78% is endocrine therapy treated alone, 55% is more than T2 tumors, and 28% were G2 tumors. If you compare this with TAILOR-X, it was primarily node, it was all of node negative cohort, primarily post-menopausal as well, and primarily node negative cohort. So this cohort is different, and we were curious whether CanAssist Breast will be able to predict the 10-year recurrences. And so here is the data. The short answer is yes, CanAssist Breast is able to segregate all the patients that we tested across the team trial so far, as well as in exemestane versus sequential arm, into two risk categories, low risk versus high risk for breast cancer recurrence at 10 years, in a very statistically significant manner, into two risk categories. The low risk patients do have a higher DMFS at 10 years. In exemestane arm looks the best compared to sequential arm. So this goes to show that CanAssist Breast is indeed able to predict even long-term 10-year distant recurrences in this cohort. And they are so excited by this data. They're trying to find more patients from this trial, which are all over Europe, and we are trying to validate this the cohort more. So all this data is great, but how is CanAssist Breast helping our patients today? So as you all know, CanAssist Breast has been in the market for last almost 6 years, sorry. More than 300 oncologists across India, Sri Lanka, Bangladesh. Recently, we also have been selling in West Asia, in Turkey, UAE, Azerbaijan, and some of the patients are also from Iraq. Actually, they have been using this test, and more than 2,500 patients treatment has been planned using result of CanAssist Breast since 2016. 71% patients have been certified as low risk for breast cancer recurrence, and they have avoided chemotherapy, leading to not only huge savings, but improved quality of life. And I will showcase the success stories. CanAssist Breast is reimbursed by multiple private and public insurance companies in India, and these are mentioned here. So if you have any patients who have insurance, we will also be happy to help them with the insurance paperwork. So now I would like to showcase some of the patients who have actually been treated using CanAssist Breast. So here is our first patient, patient Mrunal, who was at the age of 31. She was diagnosed with breast cancer. She was recently married and wanted to have a baby. She had IDC stage 2, T2 disease, high Ki67, grade 2 disease. And although she was ERPR highly positive, her age and Ki67 were really against odds with her in terms of avoiding chemotherapy. But she wanted to have a baby. So the clinician was kind enough to recommend CanAssist Breast to her in our first year of sales. And as per CanAssist Breast, she was her tumor was low risk for distant recurrence in 5 years. So the clinician suggested her that let's skip chemotherapy. You can have the baby first, and then I'll put you on endocrine therapy. Her other option was fertility preservation and then have the baby at the end of endocrine therapy. So she did exactly what the clinician suggested. She is a happy mom of a 5-year-old now, and after 1 year after she delivered, she was put on endocrine therapy, and she is doing very well without any progression of the disease. She is on endocrine therapy. There was second patient Jessie, who is again 36-year-old young woman, did not want chemotherapy, was diagnosed with T2 disease, Ki67 16%. Considering her age and Ki67, once again, she would have been given all of these modalities, but she didn't want chemotherapy. So CanAssist Breast was recommended. She was low risk for breast cancer recurrence, and she skipped chemotherapy and is doing well on endocrine therapy as on date. Third patient was a patient 56-year-old who was hesitant about chemotherapy. She had T2 disease, 30% Ki67, and grade 3 disease. So once again, because she was hesitant about chemotherapy due to age and perhaps comorbidities, treating clinicians suggested CanAssist Breast. She was low risk for breast cancer recurrence, and She was not given chemotherapy, and she is doing well on just endocrine therapy for the last 5 years. We try to follow each patient annually for 5 years minimally. All of this data, how is CanAssist Breast impacting treatment decision, is published. What do our oncologists opine about CanAssist Breast? This is published in South Asian Journal of Cancer. The survey, as well as recommendations for some of the indications, some of the patients for which CanAssist Breast can be useful. Multiple oncologists have written about CanAssist Breast in these publications. You can see them, and these are all the doctors who have used CanAssist Breast and have been kind enough to give us testimonials, as well as doctors in Turkey who have used CanAssist Breast have given us testimonials of how the test is really helping their patients, young patients in Turkey. Many doctors like Dr. Dev, Dr. Ajay Bapna, Dr. Govind Babu have talked about our data in multiple conferences such as APSICON last November, NatCon last year, and ISMPO conference in early this year in Bangalore. So to summarize, why CanAssist Breast? It has multi-country validation. It is validated on Asian, younger patients, as well as Caucasians, pre and postmenopausal disease, node negative, node positive. It is priced 4 to 5x lower than the competitors. It uses cutting edge AI/ML based algorithm. Our bigger goal is also to develop targeted drugs against the biomarkers we have, especially for patients with high risk disease. And we hope to work with pharmaceutical companies on the drug discovery aspect. CanAssist Breast is quality driven. It is run in our CAP and Enable accredited laboratory. It has CE mark and ISO 13485 accreditation. All of these guys come annually for audits, and we maintain excellent quality management system. And we have the fastest turnaround time, calendar days of 8 days. So this is all summarized here in this summary, that it is the most robust and cost effective IHC test. It is independent of cohort specific age or node status specific differences. Chemotherapy benefit is shown only in high risk patients. There is great 83 to 85% concordance between the two gold standard genomic tests commonly used across the world. CanAssist based segregation is a lot more accurate compared to commonly used free tools such as Ki67, Luminal, AB, IHC4. I didn't have the time to go through those. It prevents not only undertreatment, but as well as overtreatment. Early data showcases 71% who have been spared of chemotherapy using CanAssist Breast over last 6 years seem to do well as per the negative predictive value of the test, 95%. Patients, and CanAssist Breast is able to predict 10-year distant recurrences as per team trial. So we really believe CanAssist Breast is our solution to our problems, where the breast cancer is different from the West by in terms of having it's in younger women with node positive high Ki67 disease. So thank you all for your time. These are our publications. All are available on our website, and I will be happy to take questions.
Thank you, Dr. Manjiri Bakre, for your excellent lecture. Any question from the audience? From all the three patients you have presented, no, they are T2, N0, M0, and some of them are there Ki67, 16 to 30. Mm-hmm. This is also indicated in node positive, no?
Yes.
Like 1 to 3 or
1 to 3, yeah.
So basically indicated in T1 or T2, N0 to N3.
Correct.
HR positive, HER2 negative.
Yes, irrespective of Ki67 status.
Okay, yeah. And is indicated in less than 60 years or also more than like 65 or 70 years of age?
Yeah, more than. So we have done prospectively, we have done up to, I think, about 74 years of 74-year age patients as well.
Okay, it's both in the premenopausal as well as in the postmenopausal patients.
Yes.
Thank you. Yeah. Any question from the audience? there is no questions, Dr. Praveen?
Yes, sir.
There's one question from the audience, yeah, you can take over.
Okay. Yeah. Thanks a lot, Dr. Manjiri, for the presentation, and Dr. Nirni for the permission to be a part of this tumor board meeting, for the presentation, and also being the moderator and the patient listening. It makes a big difference in our efforts to make this innovation reach the end user, which makes any research meaningful. And trust me, it gives us immense satisfaction to be a part of a patient's effort to have a meaningful life during the treatment phase, which is a critical phase of their career, their life, sir. Thank you so much for the opportunity. And if there are no other questions, we would like to end the meeting.
Yeah, thanks, Praveen. Thanks, Dr. Nirni and the team at Omega for your time on a Friday evening. Appreciate it. And please connect with us if you have ever any questions or needed any information. Venkat is always there, and you could even write to us.
Yeah, okay.
Thank you. Bye-bye.
Thank you.
Yeah.
Good night,
Thanks.
everyone.
Yeah. Bye.
Thank you, Doctor.